Welcome. This is Sophia Assan from the Reproductive Health Supplies Coalition. And we'll get started shortly within just a few minutes. And we'll wait just one more minute before we go ahead and get started. So welcome. My name is Sophia Assan, and I am joining you from the Reproductive Health Supplies Coalition Secretariat. We welcome you to this webinar, which is hosted by the Safe Abortion Supplies Workstream of the New and Underused Reproductive Health Technologies Caucus. And we're glad that you could join us today. Please do keep yourselves muted unless you're speaking to the full group. You may enter questions and comments at any time in the chat. We will have a Q&A portion of the webinar as the final portion, and your questions and comments will be addressed then. So, and on that note, I will hand off to our co-chair of the SAS workstream, Natalie Kapp.
Great, thank you for being with us today. It's great to see everyone. For those of you with your cameras on, and at least I can see names of people popping up. It's good to see everyone. So welcome to our webinar. We have 4 esteemed speakers who will be speaking to us about access and use of post-abortion care technologies in public health facilities in Kenya. And our first speaker today is Yonu Bhatt. She's a researcher working at Rutgers with a PhD in cultural anthropology from the University of Amsterdam. Following her will be her colleague Jane Shirima, junior researcher working at APHRC with a master's degree in gender and development studies from Nairobi. Mercy Kadzu will then be speaking to us. She's a junior researcher working at APHRC with a bachelor's diploma in anthropology from Nairobi University and a postgraduate diploma in health research. And finally, we'll hear from Selma Wenju, a research officer at APHRC with a master's degree in medical anthropology from the University of Nairobi. And with that, Yona, you can go ahead.
Thank you so much, Natalie, and your colleagues for hosting us today in this webinar series. We're very pleased to be here and to share with you our research. And today we will be presenting on a part of the research we conducted. And we will focus, as Natalie already shared with you, on the access and use of post-abortion care technologies in public health facilities in Kilifi County and Kenya. Initially, we hoped to also present comparative data from Benin, where we conducted a similar study, but unfortunately, we weren't able to conclude the analysis. So we apologize for the people who also came with a great interest to learn more about research findings in Benin, but we are all available to, if you have any questions on that, we will share our contact details towards the end of the program. So nevertheless, we think we have a very interesting story to share, freshly analyzed from a large amount of data that we collected in the past year. But let me briefly tell you something more about the larger framework in which this research took place. So the research was conducted as part of the She Makes Her Safe Choice program. And this is actually a program my colleague Saskia Husken, who's here today in this webinar as well, presented to this work stream in October 2019 already. Yeah, we're now at the end of this particular program. The program is a partnership between Rutgers and DKT, and it's funded by the Dutch National Lottery with the aim to the aim of the program is to drastically contribute to reducing the number of unsafe abortions and maternal deaths worldwide, but specifically focusing also on the countries in which the program was implemented. So it's implemented by Rutgers, DKT, and many other partners in Kenya, Benin, Cameroon, and Ethiopia. And the program focuses, just to give that larger picture of where we come from. So the program focuses on the distribution of safe abortion methods, including MVA and MA, the training of providers and pharmacists, awareness raising through online and offline campaigns, and advocacy. And then there was this research component. The research was conducted by APHRC, the African Population Health Research Center, Rutgers, and the Kilifi County Department of Health. That's the beautiful logo you see on our slides. I adore it. These are the partners collaborating together on the research component of the program. And the research was intended to generate new evidence for future programs, but also for advocacy. So today we are presenting to you the research with a small team, but we stand on the shoulders of a much larger team, and we just wanted to share that with you. So we have a full team from APHRC involved in the research, Mr. Muriti from the Department of Health in Kilifi County, and then a few Rutgers colleagues. And we would like to recognize in particular the contribution of young researchers in this project. They are pictured on this slide, but we're really grateful for the work of Mercy, Jane, Sheila, and Anne in this, especially also for collecting the rich data that we're currently working with and analyzing that together with us. So having shared that, let me share a bit more on the focus of today's webinar. Today, we want to share insights into girls and young women's access to manual vacuum aspiration, MVA, and medical abortion pills, MA, as part of post-abortion care in public health facilities in Kilifi County. We want to highlight the mechanisms that explain why the supplies of these technologies, these PAC technologies, as we call them, and commodities were not always sufficient at facility level. And we want to highlight the consequences this had for young women's health and well-being. Now, maybe it's important to share that this was not an evaluation of the program, even though the program ended last year officially. but rather this was a standalone research project that we conducted in a county in which that was not a specific focus county for the She Makes Her Sick Choice program. A word on the methodology before I hand over to my colleagues to share more about these findings. So we conducted an ethnographic research, and some of you may be more familiar with it than others, and we are happy to address questions about it as well later on. But basically what an ethnographic approach offers to this kind of research is really a view from the ground. So it may be different from a supply chain management angle, for example, or quantitative research. It may also have been presented here more frequently in this work stream webinars, but this is really a qualitative approach. And we collected data during 6 months in 2021. And key to the data collection was a team of young female researchers trained by APHRC and Rutgers to conduct the research. And a key method for ethnographic research then is participant observation. So you will see that most of the data we will be presenting today comes from observation notes. And this is because we had the opportunity to do what is also often referred to as hospital ethnography or health facility ethnography. So lots of the data come from observing MVA, PAC procedures, but also more general observations in the hospital setting. And what that offers is an in-depth perspective. We were able to observe behavior of health workers, the material environment in the healthcare setting. We looked at the interactions between health workers and patients and their relatives. And we also documented informal conversations. All our work, of course, was on the basis of informed consent. So first of all, we had ethical approval for research from the national research authorities, and then also authorization from local authorities and hospital management and health facility management to conduct this research. And so that's where our data come from. And our data then was collected in a specific county in Kenya. This is Kilifi County. And we made a careful decision, selection, and we looked at specific indicators. And we noted that Kilifi County had very high rates of teenage pregnancies, but also of unsafe abortions. It also is a country with high rates of gender-based violence. And we know that that is closely related often to teenage pregnancies and unsafe abortions. So there's also a higher rate of adolescent pregnancies and live births. It's 22% in Kilifi County compared to the national average of 18%. And there's low contraceptive uptake, 33% against 53% at the national level. But if you would look more closely at our sample, then I think within our sample, unfortunately, the contraceptive uptake would even be much lower than 33%. Well, having shared this context, a bit more of the context and the methodology with you, I would like to hand over now to Mercy, who will start sharing the findings with you.
Thank you, Yona. Yeah, so I will start by setting the scene, just reading from some of our field notes, just to give you the context of how the observations were done. The woman is crying. The woman is crying in a lot of pain. The doctor says, "Sorry, mama, sorry. Try to cough. It will end soon." Then he turns to me and says, "Can you do it? Can you do an injection?" I think I had my own things. So I ask him, "What?" He asks again, "Can you do an injection?" "No," I responded. He continues to do the suction. He says he should have given the woman painkillers. His colleague could not come to help him to do the MVA. This woman is in pain. She needs painkillers. When the suction is about to end, he picks the small tube to convince, check if there is no tissue. Then the suction tube gets full. just when we thought we were done, here is more. This is just an excerpt from the field notes. Next. Yeah, so just as you have seen or from the previous quotation, there was a lot of pain that was observed during the MVA treatment. And you can also see it from one of the participants, Tatu, who was 18 years old. You can, as I read from the quote, I was seeing that I'm going to just die. I was feeling a lot of pain because there is no numbing injection. You feel the thing being pulled. That is, you feel it completely. It is not like giving birth at all. Giving birth is easier. We can also see from Penny is in pain. Dr. B has injected her with painkillers. Penny cries in pain. She bites her teeth together and is sweating profusely. So this is from the observation notes in a public facility in an urban area. Next. Yeah, and comparing from the rural and urban health facilities, we can see from the rural facilities, I asked him if the girl was given any painkillers. Then the provider responded, ever since I started being a nurse, I have never given them painkillers. We just do the procedure. This is from the rural facilities. And in the urban facilities, we see that the young women were given the medication, but it was not always sufficient. As you can see, the MVA was a very painful procedure, and the patients sometimes needed more painkillers that were not always available. And this could be due to the lack of clear guidance on pain management. So they didn't have a specific drug that they used to relieve the pain. So they used different pain medications and various dosages as they observed the patient. Next. During the procedure, sometimes the MVA equipment would be faulty, it would fail, and sometimes the procedure would take a while. For instance, Dr. C kept on changing different cannulas. He asked me to pass him different ones based on color, the green one, then the blue one. He then complained that the MVA kit was worn out since it was not creating the vacuum required. In other cases, it would malfunction and they would have to improvise, for instance, use a condom to be able to create a vacuum or use it as a lubricant. I wish we had more than one piece of equipment in the facility, the clinical officer says, while trying to fix the kit, which has some parts dislocated, while trying to pull out the blood from the equipment. This is from some observations in the rural area. Next. Due to the malfunctioning of the equipment, sometimes the procedure would take longer than expected. That's more pain for the patients. For instance, in one case, the procedure where the doctor had said that it would take 10 to 15 minutes, it took almost 1 hour since the MVA kit was faulty and wasn't creating a vacuum to suck the products of conception. Sometimes the MVA kit would break down and the doctor would struggle to push out the blood from the kit. You can witness the hassles that we go through when performing the MVA and hope your study will be of help so that we can get better equipment. This was from the field notes in a public facility in the rural area. And since the MVA procedure would take more time because of the malfunctioning equipment, it would be difficult for some doctors to complete the MVA since the patients were in more pain due to the prolonged procedures. Next. Yeah, in most cases, the health workers would encourage the women to be strong and bear the pain, and also cooperate so that the procedure would take less time. And in some cases, they would not use pain medication, since they say they reserved it for genuine cases. And for example, where they believe the abortion was spontaneous, or where the woman was older, because in most cases they believe that older women would not induce abortions, unlike younger women who they believe they didn't have spontaneous abortions. And also they also gave pain medications based on their judgment if a patient has high pain. In extreme cases, patients hear awful things like, for example, I usually tell my patients to endure the pain so that we can finish it all at once. If they scream and disturb me, then I leave them bleeding. The pain still can be there, and they might even get into sepsis and dying. I normally tell them the truth. This is from the observation notes in a public facility in an urban area. In a rural area, we see you need to open your legs. This is a provider telling the young woman, you need to open your legs widely, like when you were having sex. It was sweet then, now you will have to endure the pain. So the health workers' attitudes towards pain and towards the young women reporting with coming to the facilities with induced abortion reduce the access to proper pain medication during MVA procedure. Next. So after the patients have gone through the PAC procedure, they suffered from, they had to endure physical effects where they would have to recall the PAC procedure, and this was painful for them, so they were hesitant to recall. And sometimes they had repeat MVAs because maybe the procedure was too painful, the doctor had to stop, or the procedure the MVA didn't work the first time, so they had to go back for another MVA procedure. So it was traumatizing for these young women to even speak about their experiences. So here we see a quote of a young mother who, because she was mistreated in the facility, she was reluctant to take her daughter to the hospital, although she was sick. My daughter is sick, but I can't go to the hospital. After they shouted at me, if you won't be at the hospital, she was addressing a research assistant. If you won't be at the hospital, then I will not come. So women undergoing painful procedures were afterwards reluctant to promote safe abortion methods among their peers. I will hand over to my colleague Jen to continue with the findings. Thank you.
Thank you so much, Mercy. I'm going to take from where you've left, and I will talk about the underreporting of PAC cases leading to lack of supplies. The record keeping is deliberately poor, and this leads to tension between the healthcare providers and administration, and it causes delays in replacing the worn-out MVA kits. And I'm going to read a quote. You know, I don't understand the administration. Every time an MVA kit spoils, they take forever to replace it. They are always complaining that the people at the casualty are careless, and the people saying that know nothing about the kit. They think it is supposed to last forever. They also say that it is misused to perform criminal abortion. So they think that by not replacing the kit, they are punishing us, which in reality, they are not. When the patients come requiring MVA, I tell them to go elsewhere because what else can I do? This was a quote from a healthcare provider in an urban area, and they're talking about the casualty area, since that is the room where the MVA procedures used to be done. And the privatization of public health services obscure recording of PAC cases, which impact timely supplies. Next slide. The training of health workers. There was a difference in levels of training of the health workers who offered PAC services. Some of the medical practitioners talked about receiving training, while most of them did not have any sort of training. And not long ago, one of the medical practitioners went for some training and learned about pain management, which she terms it as MVA without pain. In this, they do something they call paracervical block, which is an anesthesia used in obstetrics, and thus they will inject some lignocaine to the cervix and to make the patient numb from the pain. This was an observation in one of the public facilities in the rural area. Another provider says that I have not received formal training on post-abortal care, which I have really asked for in the last maybe 10 to 5 years. But I believe I am better than the trained people because of the daily day-to-day training. Sorry, but I must say this, that I have been doing it and have been doing it right. I have been reading and helped a lot of people. This is a clinical officer from a public health facility. So the lack of training influences the quality of pain management as it goes from provider to provider with no guidelines that all of the healthcare providers follow. Next slide, please. There's also the healthcare provider preference for MVA over MA. MVA is perceived as more certain by certain healthcare providers. In the private facility, they give options, but the provider recommends the MVA. The provider said that when they use MA, the girls keep coming back, hence to make certain the abortion is complete, they prefer MVA. They start with an MVA, and when it fails, they go for the MA. I had a patient who started MVA, then next MA. After the MVA failed, the nurse in charge refused to give the clinical officers the drugs to complete the abortion because they perceived it as a private business deal. The clinical officers had to sort the drugs from elsewhere. For MA, majority of facility providers felt they couldn't get enough money because it was not as lucrative as the MVA. This is because the MVA is considered more profitable in the sense that the patients who uses MVA are often asked to pay more compared to using MA. Thank you. Next slide. And this brings us to the cost of post-abortion care. In Kenya, in the public health facilities, PAC is supposed to be free of charge. However, in our study, we observed that most of the time, there is a delay in services as patients are required to pay a minimum of 1,500 shillings and up to 5,000 Kenya shillings, a fee that is paid directly to the provider. And the money is shared among those in the delivery room during the procedure or goes to the owner of the private MVA kit. Here we have to note that some of these healthcare providers privately owned the MVA kits and they will get some money out of performing the PAC services. In many instances, patients who do not have the money readily available, and they have to look for ways to raise the money, causing a delay in care or in discharge. And I'm going to read an excerpt from our notes. And this is a girl who said that I was supposed to be discharged the same day after the PAC, but I didn't have the money. They said I should pay 4,500 Kenya shillings, and I called the boy and he said he is looking for money. So I continued staying there and the boy borrowed some money at work. By the time he got the money, it was already 2 weeks later. He came and he was told it was 7,000 shillings, but he only had 5,000 shillings. He talked to them and they accepted. I was then discharged and went home. Thank you. I'm going to leave the next part to my colleague, Shalmit.
Thank you, Jen. So as we have heard from the findings, most of the MVA equipments were malfunctioning, and there was also the lack of pain medication given to some of the patients. And also there was lack of understanding by the providers that pain medication was actually supposed to be administered to patients undergoing an MVA. So we did find that this amounts to obstetric violence, whereby the providers are disregarding the need for pain medication for the clients. We also found that faulty materials and lack of MVA spare components. So in particularly things like cannulas, lubricants, and rubbers, things that when the MVA equipment is being used regularly, they often wear out, and there's need for supply of new components for the MVA equipment to work as it's supposed to. So when some of these equipments are faulty or are missing spare parts, or perhaps the provider has to improvise, where perhaps they don't have lubricant, they use a condom instead, you do find that it leads to, first of all, more pain for the client. And also the treatment, instead of taking 30 minutes that it would have initially been supposed to, it ends up taking an hour, thereby prolonging the painful experience that the client undergoes. And also due to privatization of the MVA equipments, whereby some providers would actually own some of these MVA equipments, you do find that it leads to delay in care. And sometimes you find that the provider who actually owns this MVA equipment sometimes is not in the facility, and the client has to wait for about almost sometimes the entire night for her to receive the MVA procedure, maybe in the morning when the provider who has this equipment arrives. We also found that the underreporting of PAC cases leads to limited supply, whereby perhaps when these MVA equipments are used by providers to undertake private MVA procedures, they don't really report them in the PAC books, thereby the procurement office does not see the need to replace some of these equipments, because the numbers of the MVA procedures that they're reporting don't really match up to how the equipments are being used. So for example, let's say if the facility reports 4 cases of MVA in a month, and maybe the cannulas and the lubricants are getting worn out at a faster rate than the supposed 4 clients would have used, it really it brings up the issue of supply and demand, whereby they wonder who are these clients that are being seen, yet we don't see any cases being reported. Also, we found that lack of pain medication, especially the supply of pain medication in rural areas, was also lacking, meaning that patients who visit these facilities for MVAs also do suffer. So in conclusion, next please. In conclusion, access to good quality MVA care and equipment is hampered, especially for poor women and girls. And also barriers are formed by public healthcare mechanisms such as underreporting and healthcare providers privatizing public healthcare, which often leads to underuse of MA as part of PAC technology. Furthermore, limited training for providers, lack of clear guidance on pain management, and sometimes attitude from the providers which come off as judgmental. They also hinder, whereby such judgmental attitude shows how technology is deemed to improve PAC quality and ease, turning into obstetric violence with consequences for future health-seeking behavior by women and girls. and girls not wanting to recommend such a procedure to their fellow girls in the community. So we do recommend that there needs to be a clear guideline on pain medication, and also increasing the knowledge of providers on existing guidelines. Also, the use of MA in public health facilities need to be further promoted. And we also do recommend addressing harmful attitudes towards induced abortion, which could come in the form of a VCAT training for every provider that is providing such services. We also recommend that MVA kits be maintained regularly, and also making this a mainstream thing so that it doesn't get ignored as it is now. We also do recommend an accurate record keeping of PAC cases to ensure that the supply does meet the demand. And we also recommend that MVA stock keeping at public facilities be something that is highly encouraged. We also do recommend that communication about pain level, especially pain level involved in MVA and during the MVA procedures, be improved, and that healthcare providers are sensitized on such. Yes. So that concludes it, and thank you so much for giving us your time.
Thank you so much, Selma, and to the full research team, and to all who have put so much work into the research and also putting together the content for today's webinar. I just have to comment that it is, while it's not the easiest feedback to digest, it's a great way to kick off this year's SAS webinars. We already have a few questions that have been posted in the chat, so I'm going to start with those. So starting with a question from Veronique at RHSC. So I will, as we discussed, Yona, I'll state the question, and then I'll let you delegate to whoever in the team you feel would be best to answer the question. So could the team elaborate a bit further about the provider's perception that medical abortion is not as effective as MVA, and that patients who first choose medical abortion are coming back to the facility for MVA? And is this because patients are not able to access MA or following the MA guidelines or instructions correctly?
Thank you, Petra, and thank you for this question. It's a very difficult one, so I'm not really sure who to point out to. Maybe I can ask Rama to Uedraogo to respond to this question.
Sorry, I was struggling to unmute. So thanks for the question. As you said, it's not very easy, but I can try, and then the young researchers who were in the field can also chip in. I think it's stand on the fact that from the experience, they were seeing, like, when you give MA to the patient, in addition to what was presented in this webinar, when you give them the MA drug and the fact that they have to go home and continue the procedure, the process of taking it, some of them, because they are anxious because of the bleeding and the feeling that it's not being done, or the evacuation is not being done properly, they may end up coming back to the facility, which for them increase the burden. So the choice is to go for the MVA, which is right done immediately, and after it's done, the patient doesn't have to come unless it's incomplete because of other reasons as reported here. So it may be due to women not being able to follow the instruction, or maybe just fears of like maybe what is happening is not normal. I should go back and check what is happening, because we know even for the cases where women get MA at home and to induce abortion, some of them end up going back to the facilities to seek help, because they want to be sure that things that are happening in the normal way, and they are not taking any risk of going through any further complication. So it may be that, but maybe Jane and Mercy may want to add something.
Ramatu, you've tackled it well. It's because the MVA, the product of conception, is evacuated at the spot. So the doctor finishes the procedure for you while you're still at the hospital. Unlike MA, they give you the drug and you go with it home, and you might not follow the instructions well. So you might come back to the facility with complications, or you might end up having complications at home and not even come to the facility and maybe lose your life. But MVA, the doctor is sure they've finished the procedure for you, so you go home and no complications are, you're not going to come back with complications for them to handle.
So maybe I can also briefly contribute to that. Thank you so much, Mercy and Ramatu. So what I think from your explanation speaks somewhat a lack of trust as well in MA. But also, I think the other part that we try to emphasize in the presentation is the fact that, that MVA offers the opportunity to charge some money, really also plays an important role in the preference for MVA. That's just what I would like to add.
Thank you, Yona. Thank you everyone for your answers. We've quite a few questions, so I'm going to jump straight into the next one. So did you guys notice more stigma towards younger people seeking abortion services compared to older patients? That's from Emily Schechter.
I think the short answer is yes. And now Jane, yes, you were the person.
Okay, thank you.
I was going to ask. Yeah, please.
Yes, like as Yona has said, the short answer is yes. And this was noted even in the sense of pain management. For the younger patients, they were mostly not given any pain management, more as a punishment, because it is believed that the younger patients induced an abortion, even if they say it was a spontaneous one. And the older patients were treated like better, and they were offered pain management. And also, I feel like the provider's attitude was more towards the younger patients, because maybe they can't defend themselves, or they just appreciate the service that they're being offered, and they were being mistreated, talked to badly, and being threatened that if they don't cooperate, even though they're under a lot of pain, the provider will leave them and go handle other cases. So yes, age was a factor in the attitude and also the treatment procedure.
Yona, can I come in?
Sorry, Ramatu.
So I just wanted to add to what Jane said, that it's that they cannot defend themselves, but also providers maybe putting themselves in the shoes of elder people in the community, and therefore the role of educating, teaching those people, so that if you go through a lot of pain in the process of post-abortion care, you may not put yourself in that situation of getting pregnant and going for abortion. So the attitude towards the young people also can be seen that way, them playing that role of educating them somehow.
And also just to add a bit on what my colleagues Jen and Ramatu have spoken about, there was also the distinction between those who are married and who have kids, because the providers would usually assume that it was a spontaneous abortion, rather than for the young adolescent or unmarried girl, who they would automatically assume it was induced, therefore they require the punishment of the pain.
Thank you. There are no further additions. I'll move on to the next question. From Natalie, our co-chair, can the researchers describe what WHO recommendations are, or what guidelines providers are using or following, given that in the WHO guidelines, it's clearly stated that pain should be managed during abortion procedures?
Thank you, Natalie. A very important question. And we were even looking into that this morning again to what's actually there in the guidelines. And Ramatu, would you be able to give some feedback on that?
Thanks, Yona. I think although it didn't come during the discussion with the providers on which guideline they are following. Before that, it may be the 2012 guideline that was withdrawn, and I guess building on the WHO one, which clearly sets how the pain management should be done. But also, as we were saying during the presentation, there is kind of, should I say, lack of knowledge about those guidelines. Some of them were aware of it and they were using, but from what we observed in some cases, they were not aware of those guidelines, and some of them were just trying to handle, leading to what maybe I don't what we found. For instance, there were different type of drugs used as compared to what is in the guidelines, and also how to use it. The guideline is saying that you need to do the injection or give the pain medication and wait 30 minutes before starting the process, I'm sure to reduce the pain. But from what we observe, it's either it's not given or it's given different type like tramadol or lidocaine or others, and then it's provided and immediately the MVA process starts. So that may also contribute to the pain we are observing. But the discussion did not come clearly around which guideline they are following, but we assume that it may be those guidelines, adding to the fact that some of them were also not aware. Since some provider reported that they attended to training, that's when now they got a clear information on how to provide pain-free MVA to patients. You're now over.
Thank you, Rama. Maybe indeed I can add to that is that so in practice we saw many different practices in terms of pain management. So either there was no pain management or there were different medications being used. So that's why we refer to this probable lack of clear guidelines. And some of the healthcare providers definitely also acknowledged that the pain treatment they were given was not sufficient. And now this morning, and even earlier when we were preparing this presentation, we were also discussing whether it could also be the condition under which the young women present themselves in the health clinics, because we noticed that there's a delay in reporting. So we had a lot of women inducing abortion at home, trying to do that secretly, but when complications occurred, they took a long time then to report to a health clinic because of the stigma associated with abortion and especially that factor. So that may also have influenced, and this is where we lack the specialized knowledge, the condition under which women came in, whether they had advanced complications, and whether that also played a major role in the level of pain they experienced. Nevertheless, if that's the case, and if it's commonly occurring, then I think pain management guidelines should offer sufficient guidance also in those situations. So I hope that answers the question sufficiently.
Thank you, Yona. Thank you, Irma, too. So the next question's more focused on the products at the sites. Was there any experience of poor quality or unquality assured products being used? And also linked to this question, are doulas available to support women with medical abortion at home?
Sorry, I didn't get the last part of that question. What was it? Doulas available?
Yeah, so it's from
Yeah.
so is there a framework available for women to have support at home to manage their abortion? I think is the question.
Right. Well, I think I can try to answer, and then I'll ask my colleagues to add if I miss anything. So the question regarding the poor quality of uninsured products, I think we are not really able to give to comment on that. I think it was not so much the quality of the initial MVA kits, but more the way they were used and intensively used, but not, but then under reporting of their use. But that I don't think we have sufficient data to make a statement about the source of those MVA kits and their quality. But I don't know if one of my colleagues wants to come in there. It's absolutely a very relevant question. So.
Yes, Yuna, I also think so. We can say much on that. It's more of the use that is made of those kits, the intensive use, as you say, rather than the quality of it.
Right, thank you. And then the question about doulas being available to support, I'm looking back in the chat, the provision of MA at home. Well, so from what we've seen, the young women in our sample, those were 58 women that we were able to follow more closely also at home and note down their experiences with abortion. For them, we didn't notice the use of such any type of guidance. So if MA was procured, it was mostly from private pharmacies, and then it was used at home, if at all, because we saw a lot of use of traditional methods for inducing abortion. But of course, we know there's more available. There's more in Kenya. I think there are quite a few helplines that would be able to provide that kind of guidance to women using MA. So I'm not sure, I know my colleague Saskia is here as well, if you're able to say something about the availability of that kind of services in Kenya, or any of the other colleagues from Kenya may want to come in here. And sorry for putting you on the spot, Saskia.
Thanks a lot. And I'm sorry, we had some trouble with muting as well here. Yeah, I think there's a lot of opportunities, a lot of formal and informal support groups that are continuously being established in Kenya by different organizations. And of course, the helplines are there, also for guidance and for referral to quality providers. And I think that's very important, that those are trained providers from public but also private sector, and that those follow the WHO guidelines and also insist on pain management and really provide quality products, medication, but also quality services and counseling, and really listen to what a particular woman or girl would need. And I think that's where, yeah, in more remote areas, that's what's often lacking. And I think in general, if product distribution continues to grow throughout Kenya and also in other countries, it will have to go hand in hand with training of providers and the whole chain of things that are needed. And that's far from perfect. So I think this research really had a cruel but true picture on what's going on the ground and how women are experiencing this, and let it be a signal to all of us trying to improve supply chains and improve capacities of providers to continuously work, because we're not yet there and the demand is huge, as we all know. But yeah, indeed, there's different hotlines and other ways of support and chatbots, but also really on the ground networks of groups of women informing each other and supporting each other. And not all of those are possibly going to be mapped, but I think that those support networks are continuously growing. I hope that answers your question. And I can just confirm that our program, which has ended now, but that has been building on what's on the ground in Kenya as well as in other countries.
Thank you, Saskia. I think we have a few more minutes left for a few more questions. One colleague's pointed out similar research being conducted, or that has been conducted in Senegal, where it's been observed that there's been a resistance from medical staff to use MVA or MA for PAC because they perceive it as something that reduces doctors into technicians. And I think we've a little bit touched on this already, but so there's a preference for curettage. Did the researchers in Kenya observe similar patterns?
Yeah, thank you so much for that very interesting question. From my perspective, what I know from the data is that manual curettage is very rare these days. Sometimes it's a last resort, or that's how providers feel when MVA keeps failing. But from our data, it doesn't emerge as an important practice. So I think there we see a difference. I also don't recognize the sentiments that's explained here, that doctors feel they're reduced to technicians. Maybe we've been observing also a lot of clinical officers and nurses doing the MVA, but I don't recognize that sentiment. But it would be great if Mercy or Jane could say something about it, as they were really close to the health workers in their daily practice. So Jane and Mercy, do you feel that that there was some kind of resistance also from doctors or health staff to use PAC technologies like MVA and MA, because it would reduce them to technicians, so to say?
And no, that didn't come out at all during my time in the field.
Yeah, I agree with Jane. We didn't see this because for us, mostly the clinical officers and nurses and sometimes medical officers, they did the procedures. So it didn't come out from our data.
Okay, great, thank you. One final question. I think this links more broadly to the recently released WHO guidelines and the focus on self-management of abortion. Was there any information that came out in the research on adverse events as a result of self-management of medical abortion? And does the team have any recommendations on addressing the lack of trust for self-management of medical abortion? Sorry, that's a lot of questions.
Yeah, it's a very important one. I'm trying to pass it on quickly so that we can get an answer. Grace, since we haven't heard from you yet, would you be able to answer the question, or Shelmit, who looked into the methods more in depth? And while you're grabbing the microphone, let me try to give an answer, because we're out of time, but please feel free to interfere. So I think what we just didn't see a lot in our sample is the use of medical MA. So it's really hard to answer the question. Access to MA is still quite difficult. I think especially for the younger women and women in rural areas. So it relates to limited awareness still of the availability of it, but also the difficulty of obtaining it at the pharmacy. We noticed that some pharmacists provide it under the counter, and they would also ask for lots of money or other things in return. So that was not really, we don't really have a good image of this. So just like to share that we did publish recently a research report on the research conducted in Kenya, And we shared a policy brief. So we will share, I think we can, I'm not so quick in doing this at the same time, but try to share links in the chat still before we drop, because I think some of you may find answers to your questions there. And we remain available to answer any other questions you may have, maybe through email.
And same for the study in Benin also. Sorry, just wanted to add that one.
Very good point. So Rama, do you have the links to the APHRC website quickly available, where the reports and the policy briefs are?
As we're on time, I think we'll obviously, if you guys can share, that's great. But just another huge thank you to you all for your hard work on the ground, and also from the desk to prepare this webinar. I think it's been really informative and really interesting for all the participants. And I don't know if, and of course the recording of the webinar and the slides will be made available on the RHSC website and the SAS workstream page. Sophia, do you want to make any closing statements, or are we good to go?
We're good to go. Thank you very much, Petra. And thank you to everyone. As we mentioned, we'll share whatever materials we didn't have a chance to at the end by email. And we hope you have a great rest of your day. Thank you so much for joining us.
Thank you so much. Bye-bye.
Thank you all. Bye-bye.
Thanks, everyone.